Good evening and welcome. Thank you so much for joining us tonight for the webinar on treatment approaches to help manage bothersome tics, presented by Dr. Peter Morrison. My name is Katie Delaney. I am the Family and Medical Outreach Coordinator at the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your facilitator for this evening. Now, before I introduce Dr. Morrison, here are the housekeeping notes. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. If you have questions after tonight's session, you can post your questions on the Wednesday webinar blog, which is accessed from our homepage at www.njcts.org under the heading Programs. This blog will be monitored for the next 7 days. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now it's my pleasure to introduce to you our speaker for this evening, Dr. Peter Morrison. Dr. Morrison received his medical degree from the New York College of Osteopathic Medicine in 2012. He completed his medical internship, neurology residency, and clinical movement disorder fellowship at the University of Rochester. He joined their Department of Neurology in 2017, specializing in the care of patients with movement disorders, including Parkinson's disease, essential tremors, Huntington's disease, dystonia, and ataxia. Dr. Morrison has a special interest in the diagnosis and management of children and adults with Tourette syndrome and other chronic disorders, as he is the co-director of the Tourette Association of America's Center of Excellence at the University of Rochester. Dr. Morrison, we are so happy to have you here tonight. The floor is all yours.
Thank you very much, Katie. I'm really excited here tonight to be presenting this webinar. Obviously, this is a near and dear topic to me, not only because I'm a movement disorder neurologist and specialize in tics, but I am also an individual that has Tourette syndrome. And so I was diagnosed, as a child. And so, kind of going through lifespan, as the patient side of things, and now being on the provider side of things. So hopefully I'm able to provide a unique perspective for everyone. I'm really honored to be giving this, and certainly at the end, I'm happy to take any questions. So overall, kind of jumping right into it, the primary focus and objective of today's webinar is going to be looking at the range of effective management and treatment strategies for patients with bothersome tics, including both medication and non-medication approaches. With that said, it's always good to have the foundation in understanding of what tics are in different tic disorders. So I will review the phenomenology of tics, the different tic disorders that are present, because there probably is various levels of understanding of tic disorders on today's program. So I just want to make sure we all have a fair kind of playing field, a good background, and then we'll certainly jump into the crux of the lecture, including the treatment approaches. In addition, it's always good to look on what's the horizon. There's a lot of medications, which I'll be going through, that have been present for many years. But it's good to know what is out there, what is in studies, what could potentially be helpful for patients with tics going forward. So the first thing we need to do is define what is a tic. And basically, the movement disorder aspect is defining phenomenology, because there can be different movements that people have. There can be tremor, chorea, ataxia, dystonia, or tics. So that's basically describing the phenomenology. Tics are not, first of all, insects, tic-tacs, contagious, or a sign of mental instability. Rather, they are repetitive, stereotyped, non-rhythmic movements or sounds. Most of the time, tics have what's called a premonitory urge or a buildup or sensation before the movement or sound happens. Tics are involuntary, they're out of the control of the individual, but there is this temporary suppressibility component, but eventually that urge builds up, they get distracted, and the tic occurs. And a lot of times there's this relief phenomenon afterwards, or just rightism, where you kind of have to do it until it feels just right. So overall, again, understanding the definition of what a tic is being repetitive, stereotyped, non-rhythmic movements or sounds with a premonitory urge, temporary suppressibility, and a relief phenomenon. This is important to differentiate from another movement seen in children, which are also repetitive and stereotyped, but are more rhythmic movements. That would be stereotypies such as hand flapping, rocking. So again, understanding the definition of tics is really important to try to differentiate them phenomenologically from other movements that we see. So now we know what tics are, but what various tics are there? So we classify them as both motor and vocal tics. So with motor tics, that's contraction of muscles. It tends to be in the craniofacial distribution, but obviously can involve the limbs and the trunk. Vocal tics are the production of a sound. In theory, you actually have to have contraction of muscles to produce a sound. So it's more semantics than anything, but essentially you have both motor and vocal tics. Then we can characterize further in terms of simple and complex tics. Simple tics are more the traditional eye blinking, eye rolling, facial grimacing, neck twisting, throat clearing, sniffing, grunting. But then you can have more complex coordinated movements or sounds, where you can have kind of bizarre gaits, kicking, jumping, copropraxia, and then what people unfortunately think about with Tourette syndrome as coprolalia, which is very uncommon in patients with Tourette syndrome, but it does occur where we have the inappropriate swearing. But overall, basically, it's important to know there's motor tics and vocal tics. Most of the time, they're simple tics, but of course, we can have more complex coordinated vocalizations or movements. So what are the different type of tic disorders that we have? Well, the first is a provisional tic disorder. In prior DSM, it was known as a transient tic disorder, but it's been renamed as provisional tic disorder. Basically, this is the presence of motor or vocal tics for less than a year. In general, it is very common for children at some point during development to have tics. Depending upon what research or literature you look at, about 10 to 20% of children at some point will have tics. But overall, they last less than a year and do not recur. That is known as a provisional tic disorder. With that said, there are a certain amounts, about 1 to 3%, in which individuals will have tics for more than a year. And that's where it crosses the threshold of a chronic tic disorder. Again, 1 year less, provisional tic disorder, 1 year or more, chronic tic disorder. Then we get into the subset of the 3 different types of chronic tic disorder. Sounds kind of confusing, overall, but it's actually pretty straightforward. There are those individuals who have only motor tics, but no vocal tics for more than a year. That's known as a chronic motor tic disorder. Then you have those who have only vocal tics, but no motor tics. That's known as a chronic vocal tic disorder. And then there's Tourette syndrome, which is the combination of at least 2 motor tics and 1 vocal tic. So overall, sometimes I get parents that say, oh, I'm really concerned that it's Tourette syndrome, and I just wish it was a chronic motor tic disorder. But in the end, it's more semantics because the physiology is the same, regardless of just motor, vocal, or both. But Tourette syndrome was coined for the combination of both. So getting more specifically into Tourette syndrome, it was named after Dr. Georges de la Tourette in the late 1800s. And unfortunately, it was initially regarded as a psychological condition. But of course, over the years with research and understanding of it, we've transformed into understanding that it's a complex neurodevelopmental disorder with potentially a genetic component. Again, there's still a lot of research in terms of that aspect, where as in other movement disorders, for example, Huntington's disease, we know that it's specifically related to the mutation in the Huntington gene having more than 40 CAG repeats will produce the disease. Whereas in Tourette syndrome, it's not as clear. There's been some thoughts in terms of looking at the SLTRX1 gene, the histidine receptor mutation, but again, it's not really definitive. So overall, we need a lot more research looking into that, but it's likely a complex neurodevelopmental disorder with potentially a genetic component. When we talk about overall prevalence, about 0.1 to 0.5 to 1%, but again, there are more recent studies that are potentially showing that it is a little bit more common than that. The male to female ratio is actually 4 to 1, so predominantly males are more affected than females, but obviously we see it across both sexes. So what is Tourette syndrome and the different clinical features? So typically, by definition, we have to think about onset of the tics less than 18 years old. In general, on average, onset is around 5 to 8 years old, and about 90% less than 10 years old. Onset after age 18 to 21 is very unusual and atypical. And as a movement disorder neurologist, you have to think about other causes if you see adult onset of tics in someone that never had a history of tics. In general, again, a lot of what I'm going to be speaking about is generalizations regarding the data that we have. Tic severity tends to peak 9, 10, 11, 12, 13. And in the majority of individuals, tics tend to be pretty stable and or improve with age in about 75% of individuals. But again, that is not everyone. That is what we generally see, but certainly there are individuals into adulthood where tics persist and are certainly bothersome. But in terms of education to patients and families when making the diagnosis, in general, the trend is that tics remain stable or improve with age. In addition, a lot of times tics are just at the surface, the tip of the iceberg, as a lot of people like to say. And below the surface, we have to look at other comorbid conditions, ADHD, OCD, anxiety, depression, just to name a few. Because in most cases, again, not in all, if those are there, those are the symptoms that tend to persist into adulthood that are most functionally impairing. Again, I treat children and adults, people across a lifespan with Tourette syndrome and different tic disorders. And that is commonly what I see as people get into the adulthood, the tics tend to improve in general, but it's really the OCD, the anxiety, depression that continues to be most functionally impairing in day-to-day function, but again, not always. So this is an oldie but goodie. This is a graphic representation of what I was just talking about back from the journal Pediatrics in 1998, where basically we had individuals rate the severity of their tics at certain ages. Again, as you can see, kind of the onset of the development around 5, 8 years old, they tend to peak 9, 10, 11, 12, 13, and in the majority of individuals, tics improve with age. But again, it's a little bit subjective in terms of what constitutes tics to be severe. Is it one tic that's very large in amplitude and painful? Is it the frequency of tics? Is it the number of tics? So again, just because you have 1 or 10, in my opinion, doesn't necessarily count as or indicates the degree of severity. It depends on how it impacts the individual in terms of day-to-day function. And I think that's really important to keep in mind. This is another graphic representation from the JAMA Psychiatry in 2015, just regarding kind of onset of age and the distribution of symptoms. Here you see that Tourette syndrome again earlier on, as well as ADHD, tend to be pretty similar in terms of time frame of onset. But then you see the onset of the OCD, the mood disorders, anxiety, depression, kind of later on and tend to linger into adulthood. Again, these are generalizations of what we typically see, but certainly there's patient-to-patient variability. So now we've understood what tics are, what the different tic disorders are. Now we have to consider, when do we treat individuals? And the most important question as a provider, and even as a patient, a caregiver, a parent, a brother or sister, is, do we need to treat? The mere presence of whether it's tics or other movement disorders of tremor, chorea, dystonia, doesn't mean that you have to treat. If the movements are bothersome to the individual, then we consider treatment. If they're not, we likely will defer treatment. But again, it comes down to the individual. And that word bothersome has a lot of different meanings. And you have to consider the impact on activities, school, social, emotional, self-esteem. Are they causing pain, discomfort? There's a lot of different reasons why it can be bothersome, and that's why you have to individualize it to the patient. In most circumstances, when making the diagnosis, just education in and of itself can be sufficient, but not always. And if you are going to treat, the goal is tolerable suppression and not elimination of symptoms, in my opinion. Again, this goes for all different movement disorders, whether tics, chorea, tremor. The goal is to improve frequency and severity that improves quality of life. If symptoms eliminate, then that's great. But I think setting up the goals and anticipating what the goals are with the patient is really important, because if the physician does not set that up front, then they'll fall short. You want to be careful not to treat tics to appease the parents. What do I mean by that? So definitely, we've had certain circumstances. The parent comes in with the child and the parent says, Dr. Morrison, my son Johnny, he ticked 200 times on the soccer field. I really got to do something about it. And I asked Johnny, I'm like, Johnny, do the tics bother you? And he goes, no, they don't bother me at all. So I wouldn't treat. Again, it really comes down to the individual patient in terms of asking them, are they bothersome? And if how, quantifying that in terms of how they affect their day-to-day function. You also want to treat the most bothersome symptom first. What do I mean by that? Well, as I mentioned, not only could it be tics, but there could be anxiety, ADHD, anxiety, and depression. A lot of times there's going to be multiple symptoms there. And you try to triage what is the most bothersome, most impactful, treat that first and see from there. So again, they could have tics, but if the ADHD is off the charts, they have significant difficulty concentrating, focusing, there's a lot of impulsivity, maybe focus on treatment of that first and then go from there. There are other considerations. It is very common for tics to wax and wane, they ebb and flow, they come, they go, they change, they morph, okay? And certainly any new life event can be associated with worsening tics. You know, most commonly I hear that tics are worse at the beginning of the school year and they get better during the summer. Again, not always. They can ebb and flow independently of that. And again, in general, tics typically remain stable and or improve with age, but not always. So again, when making the diagnosis, I try to go through these generalizations with the parents in terms of education. A lot of times that's enough, but certainly there are going to be indications where we need to treat. And that's what we're going to jump to next. So overall, I just want to make not only the providers here on the webinar, but also family aware that the American Academy of Neurology, or the AAN, recently developed practice guidelines in terms of treating patients with Tourette syndrome and other chronic tic disorders. This was published at the 2019 meeting in Philadelphia, and so it's really important for people to be aware that we're constantly reassessing the data on these different medications and non-medication approaches to try to provide the best summary and recommendations. All right, so we've defined what tics are, what the diagnosis is, and we've discussed with the patient that, you know what, the tics are very bothersome to me. And again, is that because they're painful? There's the social emotional aspect, things like that. So what are our options here? Over the years, medications traditionally have been the mainstay, but what we've really come to know is that there's a non-medication approach known as Comprehensive Behavioral Intervention for Tics, or CBIT, which has been shown to be just as effective, first line, for treatment of bothersome tics than medications. So the first part of this treatment program is going to be focused on CBIT and the data behind it, because I truly believe and feel that it can be incredibly helpful for some individuals, but again, not always. If CBIT is ineffective, or in terms of access is an issue, then certainly we can consider medications. And the ones that I'm going to go through tonight include the alpha-2 agonists, such as Guanfacine and clonidine, Topamax or topiramate, the anti-dopaminergics, which are also commonly known as neuroleptics, dopamine blockers. There's typical, atypical. Ones will focus on the atypical or aripiprazole, Abilify, or risperidone and Risperdal. There's tetrabenazine, and then Botox or botulinum toxin. So I will briefly touch on this because I think in certain specific circumstances, it could potentially be beneficial, but we'll get into that. And again, you always want to reassess the presence of comorbidities and the impact of those comorbidities on day-to-day function, and potentially treating those as well as you're addressing the tics. So let's get into CBIT. Again, CBIT stands for Comprehensive Behavioral Intervention for Tics. This is a form of CBIT, or cognitive behavioral therapy, for treatment of tics. As I mentioned, it's considered first line for bothersome tics if accessible and if the patient has a premonitory urge, which we'll talk about. It's known as a form of habit reversal therapy. I don't like that word habit because tics aren't habits. But again, in generalization from a CBT standpoint, that's what they characterize it as. So what's the methodology? What's the idea behind it? Well, it trains patients to be aware of the tics. It really utilizes that premonitory urge, which I mentioned before as part of the phenomenology of tics that kind of build up that urge. And they develop what's called a competing motor response to help with the bothersome tic. Now, if someone doesn't have a premonitory urge, which isn't always the case with tics, about 80% plus minus, then CBIT may be helpful, because if you don't have that buildup or urge, then how are you going to develop the competing motor response? But let me describe an example of what is competing motor response. So again, this is kind of more in simplistic terms. I don't do the therapy itself, but the way that I think about it is that, let's say I have a bothersome tic of a neck rotation. When I feel that urge of buildup, maybe I'll just tuck my chin to my chest, wait till that urge passes, and then release. So you can't do the neck rotation and the chin tuck at the same time. Therefore, it's a competing motor response. Now, I have some patients who say, well, Dr. Morrison, are you just trading one tic for the other? The answer is no, because in theory, the competing motor response, which is your chin tuck, does not satisfy the urge that neck rotation does. The next question patients will say, well, Dr. Morrison, what if I have 20 different tics? How is this going to be helpful? How am I going to develop a competing motor response for 20 different tics? What I tend to tell patients is you focus on the ones that are bothersome, but the others go at the wayside per se, and a lot of times that improves frequency and severity enough from a quality of life perspective. In general, there are different providers that can offer CBIT. It can be done by psychologists, neuropsychologists, and even occupational therapists. And we're really trying to improve access for patients with CBIT, because to me, that is absolutely the rate limiting step. You may not have a provider in your area who's trained in this. So the Tourette Association of America has been, developing different training programs to get people certified in terms of trying to increase access to patients. In general, it's about 1 visit per week over 8 weeks. So one of the downfalls is you have to be committed. You have to do it once a week, travel, time, commitment, things like that. But again, there are going to be certain circumstances where CBIT may not be effective. They may not have the premonitory urge, or maybe there's some comorbidities of ADHD or anxiety that are really the more prominent symptom that kind of precludes them to kind of really focusing on the premonitory urge and developing the competing motor response. What I would say, though, during the pandemic is that with the development of telemedicine, similar to what we're doing today with the webinar, is really increased access for this. And so before, we were really just doing in-person CBIT visits. But now we're able to, with insurers, get credit for telemedicine. And so we're able to increase access to those in other parts of at least New York State who don't have someone locally to do it. Now, again, there's, difficulties with telemedicine and licensing across different states, but with the pandemic, in terms of all the difficulties that it's really produced, the one kind of silver lining has been the advancement of telemedicine and potentially increased access for those patients with CBIT. But again, we have long ways to go. So obviously, it's fine for me to say that CBIT is the number one first-line treatment, but we want to look at the evidence, right? What evidence is there to support what I'm saying? So the first was a randomized clinical trial of 126 children aged 9 to 17 with TS or chronic tic disorder. They basically separated into 2 groups. One group had 8 sessions of CBIT over 10 weeks. The other was a control group of just supportive therapy and education. And what they found was that the behavioral intervention with CBIT led to significantly greater decrease in what's known as the Yale Global Tic Severity Scale, or the YGTSS, compared with the control group. Now, overall, not getting into the nitty-gritty details of what the YGTSS is, but overall, in movement disorders, in clinical trials, we have to have motor outcomes. For Parkinson's disease, it's a UPDRS. Huntington's disease, UHDRS. Dystonia twisters, and for tics, it's the Yale Global Tic Severity Scale, or the YGTSS. And that is one of the major endpoints, at least from an objective scale, that is commonly used. In addition to the YGTSS, significant difference they found was that there's significantly more children receiving behavioral intervention compared to those in the control group were rated as either very much or much improved on the Clinical Global Impressions Improvement Scale. In the treatment group was 52.5% versus the control group was only 18.5%, and the p-value was significant. And again, the p-value, just in general, not to go into all the biostats of everything, is less than 0.05, is clinically significant. Dropout rate was lower, 9.5, 12 out of 126. And the treatment gains were durable in the sense that after 6 months post-treatment, they went back and they found that 87% of the individuals continued to have positive response to the behavioral intervention. So then they took it one step further. They said, all right, so we've seen it done in children. Let's see if this is the same in adults with tic disorders. So they did a randomized controlled trial of 122 adults aged 16 to 69 with TS or chronic tic disorder. Again, similar setup of 8 sessions of CBIT or supportive therapy over 10 weeks. And again, what they found was that behavioral intervention with CBIT resulted in significantly greater decrease on the YGTSS compared with 8 sessions of supportive therapy. In addition, similar to the pediatric study, is that more adults receiving the CBIT were rated as being very much improved or much improved on the Clinical Global Impression Improvement Scales compared to supportive treatment, and again, with a clinically significant p-value. Dropout rate was a little bit higher, but not too much, regardless of the treatment group. So again, whether they were in the CBIT or the supportive group. And the treatment gains were once again durable with benefits sustained at 6 months post-treatment. So this is a good graphic representation regarding the CGI, or the Clinical Global Impression Improvement Scale, where in the child study, 52.5% of the children found that they were either very much or much improved compared to only 18% of the control group, whereas in the adult study, it was 38.1% felt they were very much or much improved compared to only 6.4% in the control group. So overall, that's the data behind CBIT. Obviously, there's much more that's been done, but those were really the big studies to show us evidence-based that it can be very, very effective, not only for children, but also for adults. So transitioning then in the sense that, let's say we've done CBIT and tics persist and are bothersome, or maybe we don't have access to CBIT. What do we do next? Well, at that point, it is medication management. And there are different groups of medications that I'm going to go over, but in my opinion, and most of the Movement Disorder Society opinion, the alpha-2 agonists are considered the first-line treatment for bothersome tics from a medication perspective. In addition, the alpha-2 agonists can also be effective for ADHD symptoms. So if you have the presence of tics and ADHD, then potentially you could get a 2-for-1 by using an alpha-2 agonist. Now, they are not as effective from a clear effectiveness standpoint for ADHD compared to the stimulants, but certainly they can be a non-stimulant approach. They're potentially less potent than dopamine blockers, but have less potential side effects. And that's what I always look at, is what is the side effect profile when we're looking at these medications. And in general, most of the common side effects related to the alpha-2 agonists are going to be sedation, orthostatic hypotension, bradycardia, dizziness, and constipation. Because when we go back and look at the mechanism of action, it actually binds to the alpha-2 receptors in the CNS, which reduces sympathomimetic outflow, and therefore, in general, actually lowers blood pressure and heart rate. That's its primary mechanism, but indirectly can be helpful for tics. So the 2 alpha agonists that are available that most of you may or may not be familiar with are clonidine and guanfacine. Clonidine, also known as cataprest, maximum dose is about 0.4 to 0.6 milligrams daily, can be dosed BID. Catve is the extended release form. And then there's guanfacine or 10x. Maximum dose is about 4 milligrams a day. Intunib is the extended release form. And in general, in my opinion, I tend to go with guanfacine more than clonidine because I feel it's a little bit less sedating. In addition, it has a little bit longer half-life than clonidine. So a lot of times you can get away with dosing daily at night in case if it causes sedation, where it will continue to work through the day. So let's say at that point, we've done alpha-2 agonists, we've done the CBIT. I'm going to get to another medication that you could consider in the middle before going to the dopamine blockers. But I think it's important to go through those next because a lot of you are probably familiar with them. They may not be used as much, but it's really important to understand that they are out there. In terms of the mechanism, they block dopamine receptors and they have a little bit less serotonergic receptor blockade. In the past, maybe 15, 20, 25 years ago, most physicians, neurologists, psychiatrists were using them first line. But over the years, we've really come to understand that they shouldn't be used first line because we have more potential effective medications with the alpha-2 agonists and have potential less side effects, which we'll get into. There are 2 different groups of the antipsychotics or antidopaminergics or neuroleptics. There's the typical and the atypical. And the difference is that the typical tend to have more dopamine receptor blockade, and that would include Haldol and Pimozide. So in theory, the potential treatment for tics would be a little bit more with more direct dopamine blockade. But with that said, the potential side effects, including extrapyramidal side effects, which I'll go through, are a little bit higher. Then we have the atypical antipsychotics, which have a little bit less affinity for dopamine receptors and a little bit more for the serotonergic receptors. So therefore, the risk of extrapyramidal side effects are probably a little bit less, though are still possible. But with these medications, regardless of typical versus atypical, come with a different slew of side effects that you have to be concerned about. Sedation, metabolic syndrome, including weight gain, changes in blood pressure, cholesterol, glucose. So certainly as a physician, if you're starting these medications, you want to work with the pediatrician or with the other primary care provider if they're an adult to make sure that they're monitoring these things because certainly they can be effective. You can get akathisia, this kind of restlessness, ants in your pants. And then of course, the most concerning potential side effect are the extrapyramidal side effects. And that includes tardive syndromes, either as dyskinesia, oral buccal dyskinesias, dystonia. There are different tardive phenomenon. Those are the 2 most common. And then you can have Parkinsonism where you have tremor, slowness, stiffness, but again, a drug-induced phenomenon. Unfortunately, tardive syndromes can potentially be irreversible. So overall, when we think about using these medications, you want to be thoughtful, you want to be careful. And in general, if I have to, I will use the atypical antidopaminergics such as risperidone or Abilify compared to the typicals in Haldol and Pimozide. You still may see them around. The only time that really I will use Haldol or Pimozide is if someone comes in on them and they're stable, then I'll continue it. But again, you don't want to set it and forget it because the risk of the extrapyramidal side effects increase with dose, duration, and age. So the longer you're on it, at the higher the dose, the higher the risk of developing the extrapyramidal side effects. And honestly, as an adult movement disorder neurologist, when I see patients with tic disorders that are on these, I will constantly reassess the need for them. One, in general, tics improve with age, but also the risk of these side effects. And you want to use the lowest dose that improves symptoms to improve quality of life. So the next medication is Topamax or topiramate. So this is actually one that I will potentially go to before escalating to the dopamine blockers, but have already tried an alpha-2 agonist in CBIT. Mechanism of action for those providers out there has likely multiple, including carbonic anhydrase inhibition and potentially potentiating GABA-A. There was one phase 3 study done in 29 children and adults with TS. The mean age was 16.5. The mean dose during that clinical trial was about 118 milligrams. And overall, based upon the endpoints, that there was mild improvement in the outcome score for tics. But what we saw in the study, which is what I see clinically, whether I'm using Topamax for tics or something else, is the side effects. It can cause cognitive dulling, slowing. They sometimes coin it Dopamax, cause reduced appetite, weight loss, paresthesias, which is known as tingling in the hands and feet. And in adults, it can propagate kidney stones. So if anyone has a history of kidney stones, then I won't use it. Again, I think it's potentially a good option for those that have already tried CBIT and or an alpha-2 agonist before escalating to the dopamine blockers. Now, tetrabenazine. So this is a medication that's been around for a while. In my opinion, in my clinical practice, I rarely ever use it just because of the potential risk of side effects, and there's other better available options. But they are still out there, so I think it's important to know, as well as, again, in certain specific cases, could you use it? Sure. The mechanism of action is that it's a VMAT2 inhibitor or vesicular monoamine transport 2. So basically what's happening is that it depletes presynaptic formation of dopamine. With the dopamine antagonist, it was postsynaptic. Here, it's presynaptic. So what are some of the side effects? Parkinsonism, again, is something that you could see. Akathisia, this restlessness, balance difficulty. You can get prolongation of the QTC, which is part of the heart rhythm. And in addition, it unfortunately has this black box warning of worsening depression and suicidality. So again, in my clinical opinion, I rarely ever use tetrabenazine, given the potential risks and side effects, as well as our other available options, but certainly in specific scenarios, you could use it. Now, Botox. So I think this is potentially something that can be used in specific circumstances. It is definitely not the first line, and I'm going to go through what I think the good scenarios are to potentially use it. So in terms of its mechanism, it reduces the release of presynaptic acetylcholine. So as a result, it reduces the contraction of muscles and weakens it. In general, benefit is within the first 2 weeks of injections, and it wears off after 3 months. So the good news is if side effects develop, which we'll talk about, it's completely reversible. It goes away. The bad news is that if it works, you got to come back and get injections every 3 months indefinitely. Overall, one of the good aspects about Botox is that it reduces the risk of systemic side effects. What do I mean? Dizziness, lightheadedness, balance problems due to absorption systemically of the medication. In the end, the side effects are really only dependent upon where the injections are going. So if it's around the eyes, double vision, blurred vision. If it's in the neck, swallowing difficulties of the limb, weakness. It totally depends on where you're injecting that determines the side effects. In my opinion, it's sometimes helpful for simple motor tics that are not responding to typical medications and non-medication approaches. I have about 5 patients that I do Botox on. In general, it's more towards eye blinking and neck extension. Those are the 2 common scenarios that I'll use it, because they're kind of simple tics where I can go just around the eye muscles, or with neck extension, I can focus on the neck extensors. Now, it becomes a little bit more difficult if the movement is more complex, where there's coordinated multiple muscles involved in multiple directions, because then the risk of overweakness is a lot higher. So to me, if they're more simple, kind of unidirectional movements, then you could potentially use botulinum toxin. And actually, I've had pretty good success in those where they have a lot of discomfort due to neck extension or just with the repetitive eye blinking. I've had pretty good success with it, but again, it's within specific scenarios. So obviously a hot topic in the field of neurology, not just within Tourette syndrome and tic disorders, but in the field of neurology in general, whether that's Parkinson, seizures, epilepsy, is medical marijuana. And obviously I can never get through a pharmacologic lecture here without discussing medical marijuana, so I thought I'd hit it up front. Overall, unfortunately, there are just very limited, well-designed clinical trials with large sample size looking at compounds involving either THC and or CBD in treating patients with tics. The two that are out there are a little bit older and they were using THC, and I'm going to go through both of those. The first was in 2002, in which they did a randomized double-blinded crossover study of just 12 adults with TS. So essentially what happened was they got a single dose of THC, either at these 3 milligram doses or placebo. They got one dose and then the rater rated them on that single day only. They had a 4-week washout period, and then after 4 weeks got the either placebo or the THC. So again, they were just rating the scale on one day after one dose. And what they found, unfortunately, was that there was no significant differences between the treatments and clinician-rated measures on the YGTSS. So then the following year, they did another randomized double-blinded placebo-controlled study with 24 adults. All right, so doubled the amounts. Again, 12 adults is not a lot. And this time what they did was that they gave one dose over 6 weeks. So they were giving it every day. Okay, a little bit better study design. Unfortunately, 7 patients dropped out, so they ended up only having 17 to analyze. And again, unfortunately, they found no significant difference between the THC and the placebo group on the YGTSS. So in the end, from my perspective, I don't have the medical evidence in terms of supporting it. But again, I think we need more evidence, right? That's the whole point in terms of, developing clinical trials to obtain the evidence. It's not that I'm absolutely against per se, it's just that, when I make recommendations to patients, we try to use evidence-based medicine as much as possible. But again, everyone is different. But that's just my perspective. So that basically is looking at the different treatments that are available. And again, a lot of those medications have been around for years and years and years. We really haven't had something that's been novel that's developed over the last several years. So I think it's also important and exciting to think about, okay, what is on the horizon? Are there other treatment modalities out there that are being studied in tics? Are they a similar mechanism, or are they novel of different mechanisms? And that's what I'm going to go through here at the end of the lecture. The first set of medications are the newer VMAT2 inhibitors. So again, I mentioned that tetrabenazine is a VMAT2 inhibitor, and there's newer versions of it called deutetrabenazine or Austedo and valbenazine or Ingreza that have been developed, and we'll look at the data with regards to treatment of tics. Ecopipam, which is a D1 receptor antagonist, is also being studied, as well as ABX 1431. So those are the 3 newer sets of medications that we're going to look at. So for the newer VMAT2 inhibitors, let's look at deutetrabenazine first, or Austedo. So essentially the difference for the providers out there of tetrabenazine versus deutetrabenazine is that it contains deuterium atom. It's a little bit heavier, so it increases the amount of time for metabolism and therefore could reduce peak side effects such as fatigue, somnolence. Get away with twice a dose dosing instead of potentially TID like with tetrabenazine. At this point, Austedo or deutetrabenazine is approved for the treatment of tardive dyskinesia in adults in Korea associated with Huntington's disease. Given that mechanistically or chemically, it's very, very similar to tetrabenazine, it unfortunately still carries the same black box warning of worsening potential suicidality and depression. Now, in terms of this medication in the clinical trials for tics, there was the ARTIST-1, which was a phase 2 and 3 study, and the ARTIST-2 phase 3 study that in pediatric patients with moderate to severe tics, and unfortunately, that study was negative. So then the next was looking at its cousin valbenazine or Ingreza. Again, pretty similar in structure to tetrabenazine or deutetrabenazine. It's approved for tardive dyskinesia and it's dosed once a day, which is better than 2 or 3 times a day. In addition, in those clinical trials of tardive dyskinesia, it did not show worsening of underlying mood disorders, whereas with deutetrabenazine and tetrabenazine has that black box warning. So they did do a study in tics called T4. It was a phase 2 study in both adult and pediatric patients with tics, but unfortunately, both of those studies were negative. So as of now, with regards to the newer VMAT2 inhibitors, unfortunately, both of them were negative in treatment of tics. You will see some providers out there prescribing it. I've never done it, for several reasons. One, they were negative in the trials, and 2, they're pretty expensive. They're about $60,000 to $70,000 a year out of pocket. In addition, there's a specific treatment form you have to fill out and say the diagnosis, and it's really only for tardive, so I'm not sure how some of the providers get around that. But overall, unfortunately, these newer medications were negative in the treatment of tics. So let's go to ecopipam. So this is a novel medication in regards to mechanism of action, and then it has dopamine 1 receptor blockade. In terms of the neuroleptics or the antipsychotics, they were more dopamine 2 receptor blockade. So this is novel. Recently, there was a phase 2b study that was multi-center, placebo-controlled, double-blinded, randomized parallel group. Again, this is the type of clinical trial that you want, looking at 149 patients, not too bad, pediatric patients between 6 to 18. They were randomized to ecopipam or matching placebo for 12 weeks. Basically, there was a 4-week period titrating on, getting up on the dose, and then 8 weeks of the maintenance. And what they found was that the ecopipam had a significant effect from baseline to week 12 on the YGTSS total tic score, including both motor and vocal tics, with a p-value of 0.011, which is less than 0.05. So statistically significant. In addition, the mean change from baseline to week 12 on the clinical global impression of Tourette syndrome severity score was significant, as well as the global score on the YGTSS. Again, not to get into the nitty gritty, the total tic score is basically the score of the motor and vocal tics, whereas the global score is the motor, vocal, and then the impact on day-to-day function. Treatment-related adverse events occurred in 34% of patients on ecopipam and 21% in placebo. The most common were headache, insomnia, fatigue, somnolence, and restlessness. But again, they didn't see any evidence of the tardive syndromes or Parkinsonism, which are the concern with the neuroleptics and the D2 receptor blockade. There were no weight gain or other metabolic events. The main study drawbacks were that it was a smaller sample size, but again, 149 is not too bad. And the duration of treatment was a little bit short at 8 weeks, right? It's always great to potentially have as long of a treatment study as you can to show durability. Right now, they're currently in process for a phase 3 study in the future. So I think, to me, in my opinion, this has potential promise. The U of R may become a site. We'll see. They reached out to us and whether we're interested or not. But again, that's a long way in terms of actually accepting as a site and then going into the phase 3, but it is in the near future. The last is ABX 1431. So this was also had a novel mechanism of action. It's a monoacylglycerol-lipase inhibitor. So essentially, by doing that inhibition, you modulate the endocannabinoid system selectively in areas where circuits are activated. So this is not an exogenous endocannabinoid, but endogenous. So there's a phase 2 study recently, which was an 8-week multi-center randomized placebo-controlled double-blinded clinical trial at 2 doses in 49 adults with moderate to severe TS, followed by a 4-week open label. And what they found was that the YGTSS total tic score improved in both the active and the placebo group. And interestingly, the mean treatment difference at week 8 favored the placebo group and therefore did not meet its study endpoints. So overall, the conclusion is that there's no evidence that the ABX 1431 had efficacy in suppressing tics. So again, that's why it's important, at least from a medical perspective, to do these clinical trials, because we know that the placebo effect is there and that patients do improve, but we need to see that it's a statistically significant difference between them. So overall, in terms of summary for tonight, it's important to understand that Tourette syndrome is a complex neuropsychiatric condition of both not only motor and vocal tics, but also comorbidities of ADHD, anxiety, depression, OCD. In general, tics tend to remain stable and or improve with age, but certainly there are those that can continue to have bothersome tics into adulthood, for which I see. Psychiatric comorbidities are common and tend to persist with age, and in general are most impairing from a day-to-day life, but not always. You want to treat the most bothersome symptom first, whether that is the tics, whether that's the ADHD, the anxiety, or depression. And overall, you want to consider both the non-pharmacologic and CBIT or pharmacologic intervention for bothersome tics. And again, the word bothersome could mean painful, could mean the social emotional, the impact on activities. You really want to try to define that with the patient. And you also want to assess and treat their comorbidities. So overall, that is the conclusion of my lecture. Here are the references. And before the lecture ends, I always like to give a thanks to my family, my wife and children, for allowing me and giving me the chance to be able to provide these lectures to everyone. This was actually us in Barcelona in April. We went to a soccer game and had a really great time. And that concludes the lecture, and I'm happy to take questions.
Thank you so much, Pete. Everything that you said was amazing. I love the picture at the end. Your kiddos are so adorable.
Thank you.
So we have quite a lot of questions. So I'm just going to start shooting them out to you. You ready?
Sure.
Okay, so the first question we have is, How do you support an individual with Tourette syndrome in a school setting?
Yeah, so that's a really great question. Being the provider, you have a really important role. And a lot of times that could be just a letter stating what the diagnoses are, or being involved in actually the discussion of educational plans. It is not uncommon where I will actually take time out of my schedule to meet with the counselor, the school, and the teachers that's already preset to discuss how the symptoms are impactful. So I think really as a provider, you have a unique opportunity to advocate for your patients. And again, I don't do this necessarily with every single patient, but there are certainly those that you know are struggling with, whether it is the tics or the comorbidities, that going the extra effort in supporting them, whether it is part of a school meeting, education plan, can go a long way.
Thank you so much. So, our next question is, my daughter is suffering from painful tics. What to do? Looking for medical marijuana. Do you think this can help her? She's 21.
Yeah, again, so great question. So, when we talk about bothersome tics, painful tics is certainly a subset. And you can see that. It's not with everyone, but you can certainly see it. What I would say is in general, the treatment approach for painful tics is pretty similar to non-painful tics in the sense that we treat, the tics that are bothersome. But if they're painful, specifically CBIT, in my opinion, can be pretty effective in the sense that you can try to focus on that one specific tic that is very bothersome, that's causing pain, to try to develop a competing motor response. So I've had a couple of patients, for example, one was cheek biting. They kept having cheek biting, and they ended up going to the ED multiple times. Or they had someone that had a lot of abdominal tension, and it was causing increased pressure, and he was having, some vessels pop in the eye. And so they actually did pretty well with CBIT because we really focused on that one specific tic that was bothersome and uncomfortable to develop a competing motor response. Other times, like with Botox, if there is like a neck extension tic that's bothersome and painful, that can be helpful. But again, really just looking at the different treatment modalities are going to be pretty similar for painful tics or not.
And then another question we have is, and this is more towards the beginning of your presentation. They had said, why is having non-rhythmic tics important to a diagnosis? And does it have to do with having complex versus simple tics?
Yeah, so it gets back to phenomenology because not all movements are tics, right? And kids do interesting movements. So you really got to define what they are. And by definition, tics are non-rhythmic, quick and done. Whereas more rhythmic movements could be tremor, could be stereotypy. So again, understanding rhythmicity, whether it looks like a rhythm versus non-rhythmic, is important in terms of understanding the phenomenology, which then dictates what the diagnosis is going to be. So again, you can have a lot of things that are back-to-back that are non-rhythmic, like myoclonus is also non-rhythmic. But if you have a lot of myoclonus kind of back-to-back, it can look more rhythmic, but they're discrete individual movements. So again, that's how you really help differentiate you and define what the movement is first, which then dictates what your diagnosis is going to be.
Okay, perfect. And then if a child starts showing signs of tics at a very young age, does that mean that they are more susceptible to having Tourette syndrome or a tic disorder versus it going away and it just being like one tic for a short period of time in childhood?
So yeah, so is the question at the age of onset of tics, does that help differentiate whether it's going to be a provisional tic disorder versus more of a chronic tic disorder? Again, I don't know if the person could respond, but that's, I think, what they're asking.
I believe so, yes.
Yeah, I don't know if we have data in terms of saying the age of onset of the tic determines whether or not it will be present for less than a year or more for a year. Again, so I don't know if we have the data on that. In general, it tends to be 5 to 8, but I certainly have kids that have age of onset at 3. And again, age of onset per se doesn't necessarily dictate severity down the road, right? If they're there for more than a year, regardless, it's a chronic tic disorder. But it doesn't necessarily dictate severity per se. At least in the studies that we have in my clinical experience, because certainly you could have the development of tics at 9, 10, and they can still be pretty significant, and have the development at 3, but not necessarily be significant.
And then our next question is, when you were talking about frequently changing tics, did you mean having different motor and vocal tics?
Yes, yeah. So again, you can start with an eye blinking, and then it goes to an eye roll, and then it goes to a nose wrinkle, and then a neck, and then it can be throat clearing, and later on it can be sniffing. So a lot of times they come and go. They may be all there at one point, but some come to the forefront, then they recede, others come to the forefront and then recede. So it is very common for motor and vocal tics to change. First, again, patients say, or parents were like, oh, it was an eye blinking, last a couple of months, they started doing this weird sound, and then it started being a head nod. So it is very common. That is classic for tics to change and morph over time.
Okay. And then, so Tourette diagnoses commonly include ADHD. Medications such as Adderall help ADHD but seem to flare up tic activity. Are stimulant medications like Adderall clinically proven to be problematic for tic control?
That is an excellent question. I'm glad that brought it up because that is another one of the common questions that I get. And I think it's helpful that I help try to clarify based on the data. Unfortunately, over the years, there has been a misnomer that stimulants such as Adderall, methylphenidate, whatever it may be, worsen or produce the onset of tics. We actually have clinical data and a meta-analysis from 2015 in the Journal of Psychiatry that showed that wasn't the case. And actually, there was one specific trial that we had where we had one with tics and ADHD where they got clonidine stimulants, clonidine and guanfacine and placebo, okay? All three of those treatment groups, whether it's clonidine, stimulant, or both, all improved. So overall, based upon our meta-analysis from 2015, it did not show that tics worsen with stimulant use. With that said, again, there are certainly individuals that come to me after starting a stimulant that say their tics worsen. Again, because we're talking about generalizations based on what the studies show. I never like to say absolutely. I guess my point is, based on what the data is available, if someone has tics and pretty significant ADHD, and the ADHD is very impairing, I will not be afraid to try a stimulant to see if we can improve the ADHD. If it happens to worsen tics per their perspective, then sure, we'll rethink. But I won't be afraid to use a stimulant with the presence of tics.
Okay, that really was a great question and answer. Thank you so much. In addition, we have more and more questions piling in. I love it.
I'm
Okay.
trying to do my best.
Oh no, you're doing great. No worries. So another person asked, I'm aware of 2 CBIT online programs. Do you think they're worth having my child go to?
Yes, I do. And again, it comes down to access. Because again, in theory, having an in-person provider is always the best, but you don't have access to that at times. So there are several online modules, one being Tic Helper, I think. I'm not sure the other one that they may be referring to, but there certainly are several that I would definitely recommend that because at least it's something better than not providing it. The thing with the online is that they're modules, they're taped, they're not live. But again, I definitely, even before the pandemic, that's actually what I was recommending to people that didn't have access to in-person CBIT. Now that telemedicine's become a little bit better, but I still definitely would recommend it. But again, it costs money financially, so you have to consider those options, but I think they are helpful, yes.
Okay, and that's great to know. Thank you. So another question we have is, are there any treatment successes using mindfulness practice?
Yeah, I think so. Certainly not everything's medication, and that's also what I want to make clear, right? In that, we have different tools to treat tics, but certainly outside of CBIT, mindfulness, things like that can certainly be helpful because a lot of times in general, we'll see tics increase when anxious, nervous, worry, tense, and vice versa, right? If you're having a lot of tics, you're going to be pretty anxious. If you're having a lot of anxiousness, you're going to have a lot of tics. So I think using mindfulness and other things like that certainly could be an added benefit for patients.
Okay, and then someone mentioned, what are your views on New Pulse? It is a wearable technology in which you wear a device around your wrist and it applies a mild electrical stimulation in rhythmic patterns to help reduce the frequency, intensity, and the urge to tic.
I don't know, actually. I'm not as familiar with that. Just being honest and transparent, I'm not as familiar with that. So I don't really have a comment for that. I'm happy, again, I can certainly look into that. Yeah, at least in the Movement Disorder Society, it's not something that's clearly glaring that everyone's doing. I don't know much about it, so don't have a lot of comment, unfortunately, but I can certainly look into it.
Yeah, no worries whatsoever. Someone else said, do you see a relationship between strep throat and Tourette onset? I know, right?
All right. Yeah, I guess I can never avoid that question, right? Yeah. So listen. So yeah, little bit outside the scope, I think, of today. But listen, so, certainly, I think people are referring to PANDAS, and, Tourette syndrome and neuropsychiatric development. And so, I just want to acknowledge that, it's a controversial topic. It's a very emotional topic, okay? And so, at least from my perspective, since the question was asked, from my medical opinion, I don't see any evidence relating the, development of strep and then the onset of tics or neuropsychiatric condition, okay? That's just my opinion in general. There was a recent meta-analysis that was done in the journal Pediatrics by John Mink, Harvey Singer, and then one, I can't remember the third author, that looked through all the data and didn't show clear. So I guess, in my opinion, certainly if there's strep causing strep throat, kidney, right, treat. But if it's the presence of strep and tics only, I don't recommend to treat with antibiotics or different immune therapy. Again, it's controversial. It's a very emotional topic. I totally understand. And we'll kind of leave it at that, because again, we could have a whole lecture on that for sure. But that's my opinion.
Okay, well, thank you so much for answering that question. I appreciate it. So we still have a few more minutes. Another question that just came in is there any research being done with misophonia as a comorbidity to Tourette syndrome? This individual's child, their tics increase significantly with certain sound triggers or things having to do with misophonia, and CBIT did not help in those situations.
Yeah, so I'm not aware of any current active research that is looking at misophonia specifically in the relationship or worsening of tic assessment. So not that I'm aware of specifically in terms of ongoing. But again, there's a lot of different research, both medication, not right then in these correlations, not just looking at treatment approach, but comorbidities, association, epidemiology, prevalence. So not that I'm aware of.
Okay, gotcha. And then what are your thoughts related to, I'm totally going to butcher this, so bear with me, flufenazine?
Fluvenazine, yeah. Yeah, so
And,
fluvenazine, yeah, go ahead.
sorry, so flufenazine and or Lyrica being used for Tourette treatment.
Okay, so with regards to fluvenazine, that actually is one of the typical antipsychotics. I didn't put it up there. Haldol and pimozide are the two most common, but fluvenazine had been commonly used over the years. In terms of my opinion, again, it's part of that typical antipsychotic regimen in terms of, potential risks and side effects, extrapyramidal side effects, tardive syndromes, Parkinsonism. I really stay away, in my opinion, from the typical antipsychotics. I feel like there's a lot of other better options in terms of CBIT, alpha-2 agonists, Topamax potentially help. And if we have to, I personally choose the atypicals in terms of risperidone and Abilify first. So I actually have never used flufenazine. I have one or two people that are on ORAP, which are again part of that typical antipsychotic. Those patients have been on it and they came to me on it and they're very stable, so I've kept it. But I've not had a patient with fluvenazine or tried fluvenazine, but I know certainly in the past it had been used before the development of these other medications.
Okay, that's good to know. Another question we have is, do you have any patients that have tics that have gotten worse in adulthood?
Yeah, for sure. For sure. Again, what I talked about is just, generalizations regarding what we have, but it doesn't encompass everyone, right? I absolutely have a subset of individuals where tics, maybe for a while were well controlled and then something happened and the tics kind of unmasked again. Definitely, I see that. But the treatment approach is pretty similar, in terms of, trying to do CBIT, trying to do medications, but I definitely have those individuals for whatever reason where the tics are worse in adulthood, for sure.
I know that for me, my tics have gotten worse in adulthood.
Yeah,
So.
and again, and I definitely see that, and I am actively treating them. And what I would say is I've had success in those individuals who had reemergence or worsening of tics in adulthood. Though with that said, there are some that have persistence of tics no matter what I've done. But again, that's a smaller percentage, but it does happen.
Perfect. Well, thank you. And then I have a whole bunch of more questions, but I'm gonna ask one more because I know we're running out of time. So I have, while it feels extreme, I've heard that there has been more talk about deep brain stimulation. What are your thoughts?
Yeah. So again, another very, very excellent question. So DBS, or deep brain stimulation, is used in different movement disorders already that are approved for Parkinson's disease, essential tremor, dystonia, tardive dyskinesia. In terms of Tourette syndrome, there are certainly individuals that have gotten on a very, very case-by-case circumstance, okay? And at the AAN in 2019, really they kind of provided some degree of guidance about that. Really you've had to have exhausted all of the different medication options. The tics are very impairing quality of life. And also very importantly, the treatment of the comorbidities are well controlled, the anxiety, the depression, OCD, because certainly there's a lot of overlay there. And certainly on case-by-case circumstance, DBS has been done. We have never done it at U of R, but there are different institutions around the country and in the world that have done it. And there is a DBS registry for patients with Tourette syndrome. What I would say is you want to be a little careful as well, because in general, especially in the younger age, where, like I said, in general, tics kind of creep up in severity and then in general they improve with age. So you want to be careful about doing a major neurosurgical intervention in a younger child when in general tics improve with age. So again, that's just my point. It's just you want to be very, very careful that you don't want to do a major intervention when in general symptoms will improve on their own, but not always, but it is case by case and it is done. We have never done one at the U of R.
Okay, thank you so much. So I know it's 8:31 right now. If you guys need to hop off, feel free. We are going to stay on if that's okay with you, Dr. Morrison, to go through the remainder of questions. I do have a few more. For those that do need to log off, our next presentation will be on What Does It Mean to Have ADHD by Dr. Eric Deibler on Wednesday, December 7th at 7:30 p.m. EST. The webinar blog is now open and available for the next 7 days on the NJCTS website. For any additional questions that were not covered tonight, that website is www.njcts.org. Also, a archive recording of tonight's webinar will be posted to the website. For those that need to log off, I hope you have a wonderful evening and thank you so much for attending. For those that are still with us, I'm going to go through the other questions. And Pete, thank you so much for staying on a little bit longer with us.
How many more are there just from a time standpoint?
I believe there's like 5 or 6, maybe.
Okay, that's fine. Yeah, we'll get through as much as we can, just because also it's getting first bedtime.
Yeah, no, of course. And if you need to hop off, just let me know. I don't want to.
Yeah, I can answer certainly whatever ones are left for sure.
Okay, thank you so much. So we have. Okay, bear with me. What are your thoughts on Lyrica being used as a treatment?
Oh yes, I'm sorry. Yeah, I didn't. So I apologize because there were 2 medications there. So from a clinical standpoint, I don't think there's a lot of data using Lyrica for the treatment of tics. A lot of times Lyrica is used for different pain, different syndromes, as well as can be helpful with antidepressant, things like that. So again, sometimes if there's overlying pain, discomfort, mood, it can be helpful, but I've never used it specifically to target tics, in my opinion. I don't think there's a lot of literature per se out there on it.
Okay, and then I have another one that says, do you see patients for consult or second opinion by telehealth?
Yeah, so great question. So obviously I do see many second opinion, but typically not by telehealth. To me, when there's a new patient, second opinion in person is the way to go, because I can do a full neurologic exam, testing tone, strength, balance, gait. Certainly there are roles for telemedicine, especially in follow-ups, and a lot of times the exams are normal in general in patients with tics, but I really steer away from doing new patient consults via telemedicine because I really feel there's value to the in-person exam initially. The second aspect of that is that being licensed in New York State, I can only do telehealth in patients that are in New York State at the time of the visit. So if the person's in Pennsylvania, Florida, whatever, I can't do across state lines. So there are regulational licensing issues as well.
Okay. And thank you so much. I know that we've talked about that as well.
Yeah.
And then I'm just going to ask one more. The rest of these will be on the website. So the last one will be, what would be the perfect dose of Guanfacine for a 10-year-old child? This person's child is on 1 milligram and it stopped working.
Yep, so I think going to 2 would be fine. Again, it's based on, what their blood pressure and heart rate is. You want to be a little bit careful not to drop it too much, but I'd say maximum dose is 4 in general. But I think if they're tolerating well and the tics, have persisted, or maybe there's initial improvement and then continued on, eventually going to 1.5 or even 2 would be the next step, but I always do it stage-wise.
Okay. So I know that we had so many questions. Thank you so much, Dr. Morrison.
No
And thank
problem.
you to everybody for joining our webinar tonight on treatment approaches to help manage bothersome tics. There is an exit survey. Please take a moment to complete it. The webinar blog is now open and available for the next 7 days on the NJCTS website for any additional questions that were not covered tonight. That website is www.njcts.org. Also, once again, an archive recording of tonight's webinar will be posted to our website. Like I said before, our next presentation will be on What Does It Mean to Have ADHD by Dr. Eric Deibler on Wednesday, December 7th at 7:30 p.m. Eastern Standard Time. This ends tonight's webinar. Thank you once again so much, Dr. Morrison, for your presentation, and thank you everyone for attending. We hope that you have a wonderful night.